Welcome to this presentation on the anesthesia consideration for the pregnant patient. I am Dr. Yasser Osman, and in the next series of slides, we will explore the unique physiological, pharmacological, and clinical factors that guide safe anesthetic care during pregnancy. Every year, 1 to 2% of pregnant women require non-obstetric surgeries. The most common reasons include appendicitis, cholecystitis, ovarian torsion or cysts, and trauma such as orthopedic injuries or the need for exploratory laparotomy. These procedures occur across all timeline of pregnancy. So, anesthesiologists must be prepared to manage surgical emergency at any stage of pregnancy. In caring for the pregnant patient, there are two patients, but the mother remains the primary one. A healthy, stable mother provides the safest environment for the fetus. Our goal are to maintain uterine blood flow and oxygen delivery, avoid teratogenic exposure during the critical developmental periods, and the reduction of the risk of premature labor by minimizing stress and physiological instability. When possible, elective surgery should be postponed until at least the 6 weeks after delivery. For urgent procedures such as symptomatic cholecystitis, the safest window is typically the second trimester, when organogenesis is complete and miscarriage risk is low. Emergency surgery, however, should never be delayed. In this situation, untreated surgical disease poses a far greater risk to both mother and fetus than anesthesia does. Pregnancy induces extensive physiological changes affecting virtually every organ system. These adaptations support fetal development, but they also influence anesthetic management, drug distribution, airway handling, and hemodynamic stability. After around 20 weeks of gestation, the enlarged uterus in this time can compress the inferior vena cava and the aorta, reducing venous return and cardiac output by up to 40%. This makes left uterine displacement very essential to maintain the circulation. Blood volume increases significantly also, leading to relative anemia, while cardiac output rise by 30 to 50%. Heart rate also increases and systemic vascular resistance falls. All of these changes influence fluid management, anesthetic depth, and responsiveness to vasopressors. These changes begin early in pregnancy and peak in the second trimester. Aortocaval compression becomes a major concern, especially under neuroaxial anesthesia, where sympathetic tone is reduced. In the supine position, hypotension can develop quickly. The expanding uterus also increases venous pressure in the lower limb, contributing to edema and high risk of deep vein thrombosis. Maternal respiratory physiological changes. This include that the minute ventilation increases by about 50%, mostly through increased tidal volume, not respiratory rate. As a result, maternal carbon dioxide level decreases to around 30 mm of mercury. producing a compensated respiratory alkalosis. Oxygen consumption rises while functional residual capacity falls, which means pregnant patients desaturate much more rapidly during apnea. Airway tissue become more vascular and edematous, so intubation can be more challenging. So using a smaller endotracheal tube is often advisable. These respiratory changes means that hypoxia can develop quickly, especially during intubation trials, particularly in patients with obese or preeclampsia. Airway swelling and decreased glottic opening increases the likelihood of both difficult ventilation and difficult intubation, which adds to the respiration problem. Not surprisingly, loss of airway control is one of the leading causes of anesthesia-related mortalities. So, key clinical implications. These physiological changes underscores the need for left uterine displacement, careful airway protection, and a thoughtful anesthetic planning. Although gastric emptying may remain normal, reduced lower esophageal sphincter tone increase the risk of aspiration. So whenever possible, regional anesthesia is preferred to avoid airway manipulation and reduce fetal drug exposure. If general anesthesia is required, airway management must be performed with great caution. Now, let's talk about fetal physiology and risks. Fetal oxygenation depends entirely on maternal oxygenation, hemoglobin and concentration, uterine blood flow, and placental function. Uterine blood flow lacks autoregulation, so it is directly influenced by maternal blood pressure and vascular tone. Factors such as maternal hypotension, excessive hypocapnia, stress, or vasoconstricting drugs can all reduce perfusion. Fetal risks, the big three. The most important fetal risks are teratogenic effect during early development, and secondly, preterm labor, typically related to the surgical site rather than the anesthesia itself, and lastly, the fetal asphyxia caused by maternal hypoxia, hypotension, or acidosis. Fortunately, no commonly used anesthetic drugs or agents have been shown to be teratogenic in standard clinical doses. How to avoid fetal asphyxia? Preventing maternal hypoxia and hypotension is crucial for this idea. Prolonged maternal hypoxia can reduce uteroplacental perfusion, leading to fetal acidosis and even death. Both hypercarbia and hypocarbia can impair uterine blood flow. So, maintaining normal maternal carbon dioxide level is very essential. Intravenous fluid should be administered appropriately, and vasopressors such as phenylephrine or ephedrine can be used safely to support the maternal blood pressure. Preoperative assessment of a pregnant patient undergoing a surgery, non-obstetric, of course. In this case, we have to have a multidisciplinary approach is recommended, involving obstetrics, anesthesia, surgery, and neonatology. course when necessary. Assessments should include gestational age, maternal comorbidities, airway evaluation, and appropriate laboratory studies. Fetal assessment varies depending on the viability of the fetus. Before viability, i.e. before the 24th week of gestation, we do this evaluation with Doppler to detect the fetal heart rate and tone. After the viability, which is after the 24th week, we do more formal monitoring like formal ultrasound. Fetal monitoring. Fetal monitoring during surgery remains a debatable topic. Monitoring may provide early warning for fetal compromise, but it can also complicate positioning and delay urgent procedure. For viable pregnancy, continuous monitoring may be considered provided a qualified provider is present to interpret the tracing. From around the 18 to 22 week, fetal heart rate monitoring becomes practical, and by the 25th week, we can clearly see heart rate variability. Loss of variability under general anesthesia is not necessarily a sign of distress. However, deceleration should always be taken seriously as they may indicate compromised uteroplacental circulation. Selection of anesthetic technique depends on the procedure, maternal condition, and fetal considerations. Both regional and general anesthesia have a role, and the choice should be individualized to optimize maternal and fetal safety. Regional anesthesia avoid airway manipulation, reduce sympathetic response, and minimize fetal drug exposure. It is ideal for lower abdominal, perineal, or lower extremity surgery. However, it can cause maternal hypotension, so careful monitoring and proper treatment of hypotential are essential. General anesthesia is indicated for major abdominal or thoracic surgeries. Patient preference or when regional anesthesia is contraindicated. Pre-oxygenation is critical due to rapid desaturation and very short safe apnea period. Rapid sequence induction is recommended because of aspiration risk, and left uterine displacement must be maintained throughout the surgery. Ventilation should aim for normal pregnancy carbon dioxide levels. Pregnancy alters the pharmacodynamics and pharmacokinetics of many anesthetic agents. Understanding which drug cross the placenta and how maternal physiology affect drug response is essential for safe practice. Certain medications such as ACE inhibitor, alcohol, lithium, antithyroid drugs, some anticonvulsant, tetracyclines, chemotherapy agent, cocaine, and warfarin are known to pose teratogenic risks and can cause teratogenic effect on the fetus. These drugs are not typically used in anesthesia but may be relevant in a patient medical history. Most induction agents are considered safe in pregnancy. Propofol is widely used. Thiopental crosses the placenta but is generally safe in appropriate doses. Ketamine may increase the uterine tone later in pregnancy, though it remains useful in certain situations. Etomidate offers hemodynamic stability and is also safe. Succinylsonium has minimum placental transfer and remains the first-line agent for rapid sequence induction. On the other hand, non-depolarizing agents like rocuronium or atracurium can also cross the placenta barrier minimally. Pregnant patients may be more sensitive to these medications, so uh, we have to do monitoring of the neuromuscular function is recommended. While inhalational agents are not associated with teratogenicity in humans at clinical concentrations, they cause some dose-dependent uterine relaxation though this is usually insignificant at low MAC levels. Nitrous oxide should be used cautiously, especially in the first trimester. Both phenylephrine and ephedrine can be used to treat maternal hypotension. Phenylephrine is now often preferred due to better fetal acid-base outcome. The overall goal is to maintain maternal blood pressure within about 20% of baseline. Postoperative care includes left uterine displacement, appropriate multimodal analgesia, and avoidance of nonsteroidal anti-inflammatory drugs in late pregnancy. Thromboprophylaxis is important given the hypercoagulable state of pregnancy. Patients should also be monitored for signs of premature labor. Special scenarios. Certain clinical situations require tailored anesthetic planning, for example, trauma, fetal distress, severe maternal disease, or surgeries with significant physiological impact. For example, laparoscopy. Laparoscopy offers a faster recovery with less postoperative pain, but pneumoperitoneum can affect venous return and uterine blood flow. Insufflation pressure should be kept below 12 to 15 millimeter of mercury, and maternal carbon dioxide level should be carefully monitored. Another example is the cardiopulmonary resuscitation. As cardiopulmonary resuscitation in pregnancy present a unique challenge because of aortocaval compression and increased physiological demands. If return of spontaneous circulation is not achieved within 4 minutes, pre-mortem cesarean delivery should be considered to improve maternal outcome. In certain conditions, such as appendicitis, tocolytic therapy may be associated with a complication such as ARDS. Hypotensive anesthesia should also be used cautiously, and vasodilators such as nitroglycerin or hydralazine may be employed if needed. To summarize, never delay urgent or life-saving surgeries. Always apply left uterine displacement after the 20 weeks of gestation. Maternal stability remains the most reliable indicator for fetal well-being. Most anesthetic drugs are safe when used appropriately. Prepare for a difficult airway, pre-oxygenate well, and in involve obstetrician early in the planning of the surgery. Thank you for your attention. I hope this discussion has provided a clear and practical overview of anesthetic consideration in pregnancy.